And now it's my pleasure to introduce Dr. Andrew Kang, who will give a talk on SARS-CoV-2 infection in children with cancer, the Memorial Sloan Kettering experience. Dr. Kang is Chair of Pediatrics at Memorial Sloan Kettering. He oversees the clinical research and educational missions of the department and MSK Kids, and specializes in caring for patients using cancer genomics, in particular studying the genetic changes related to cancer, precision medicine, tailoring treatment to the biology of the disease, and stem cell transplantation. In his research, Dr. Kang focuses on identifying the causes of pediatric cancers and developing new treatments to benefit children and teens with these diseases. Let me add also, he's been one of the first ones to report on the impact of COVID-19 on children with cancer, both ways, both in terms of the risk factor that cancer presents in terms of severity of COVID-19, but also how COVID-19 impacted on the care of children with cancer through the experience in New York. Andrew, please.
Great, Gigi, thank you very much. It's my pleasure to be able to share our institutional experience. As everyone will appreciate, New York City was the tip of the spear in terms of the pandemic in the United States. And so we had published an experience describing our approach during the height of the first wave of the pandemic. And so I'll largely present that data, but also then give an update as we've surmounted the first wave and now a second wave to see how the data has progressed. Starting off with my disclosures, I have no financial disclosures relevant to this presentation. I don't think any of us thought we would be sitting here talking about a infectious disease as a cancer doc at this point. So no relevant financial disclosures. Now, by way of context, let me just describe a little bit our practice. MSK Kids is the pediatric program within Memorial Sloan Kettering. We're one of the largest pediatric cancer programs in the nation, seeing about 800 to 850 new patients every year. We have about 30,000 outpatient visits and care for about 130, 150 outpatient visits each day. Our demographic is heavily tilted towards relapse refractory disease, with, in our case, solid tumors being more common than heme malignancies, which is different than the usual demographics of pediatric cancers. And we see predominantly cancer patients and transplant patients, although we do care for a portion of our population, our primary immunodeficiency patients prior to transplant. This is a heat map. And as you can see, as of 2020, New York City was really at the front of the wave. And so we thought it would be important to distill our experience for the sort of guidance, if you will, of the rest of the country to follow. And so we summarized our experience through April of 2020 in the first publication that Gigi referred to. And obviously, this particular heat map is no longer relevant. And so many of the lessons that we had tried to impart within that publication are already lessons that everyone else has learned at this point. As the incidence of SARS-CoV-2 infection increased in the general population shown on the dotted line, so too we saw an increase in incidence within our patients. Now, remember, this was a time when testing was very, very limited, and coming up with those workflows that would safeguard our patients and the families and caregivers was a constant point of discussion. And there were some lessons early on as related to the care of the pediatric patient that we had to learn, through basically policy changes that weren't aligned with the care of the pediatric patient. And so as the pandemic sort of and the numbers took hold, we approached it within our pediatric group by nucleating a command center, if you will, that would be responsible for implementing those changes in our practice methods that would help safeguard the patient's volume reduction, PPE usage, distancing, changing of staffing, all things that I think everyone on this call has had to contend with. But we thought it important to have a pediatric devoted workforce within a general cancer hospital, because there are some considerations that are pediatric specific. The numbers that we published in the summer of or early in 2020 was basically based on about a month of testing, a month experience into the pandemic. And at that time, these were the demographics of the testing. And, you know, at the time, the numbers that we have here in terms of the number of patients tested was the largest, I think, outside of the experience in China. And at the time, because testing was so restricted, one of the things that we wanted to make sure that we implement that was not necessarily apparent was that in addition to implementing testing of the symptomatic and the screen positive patients, to actually be able to start testing in the asymptomatic patients, but also relevant to our pediatric population, that there are caregivers that have to be thought of as a unit to the patient that also needed to be afforded that rather restricted testing at the time, and to not restrict that testing to merely symptomatic caregivers. We also instituted repeat testing of patients very early on in the course of the pandemic. Now, these are some numbers that, again, I would underscore was at the height of the first wave, and some of the take-home lessons from what we found by implementing asymptomatic testing very early was that indeed the positivity for SARS-CoV-2 was pretty high in patients who were symptomatic or screen positive, 29%, but there was a asymptomatic carrier rate even in children that was low, but not zero. And so this mitigated our approach as related to, for example, procedures with anesthesia. We felt it important that even though the rate was low in terms of asymptomatic carriers, that one had to implement universal testing because there was a carrier rate. Now, the thing that was really unexpected at the time that really informed our infection control policies was that actually in the asymptomatic caregivers of our patients, those caregivers that were accompanying our patients to clinic or for their inpatient admission, the rate of positivity was actually nearly 15%. And so this obviously had clear implications in terms of infection control policies. And in retrospect, I think that we really shouldn't have been surprised by this high number. There was a parallel publication out of Columbia University describing the pre-delivery testing of asymptomatic women going into labor, and the rate at that point was also reported at nearly 15%. And so the 15% really probably just reflected the rate of positivity in the general population at that time. And so we subsequently within the institution actually used the asymptomatic caregiver testing as the canary in the coal mine for policy setting across the institution. Now, it was of interest to us that in the cases where the caregivers were positive, only half the time was there concordant positivity in the child being cared for by the caregiver. And so this lower asymptomatic carrier rate in children, at the time, this was sort of a first signal of some difference in biology as related to infectivity. And obviously, we weren't the ones that subsequently drilled down what the mechanistic explanation was, but that was sort of a empiric signal of that likelihood. Most of the patients, importantly, going into this, we also did not know how the heavily treated cancer patient would fare in terms of symptomatology. There were publications at this time coming out of China in adult patients indicating that cancer was a risk factor. If you drill down on that data, then it becomes evident that it's largely lung cancer patients, and that's obviously not a disease type we see in pediatrics. And so we really, though, did not know at the time. And based on our initial publication, most of the patients had very mild symptoms and were not hospitalized. Actually, out of the initial cohort of 178 patients, only a single patient required hospitalization and just received supplemental oxygen. And the subsequent, I'll give you an update that, we clearly had more patients requiring hospitalization, but there was no mortality in this initial phase. And so that took us through, in essence, the height of the pandemic last year. All the numbers have moderated as the general prevalence within the population has moderated. This is a screenshot from a tracker that we have that I took 2 days ago. This is showing the number of tests through the course of the last few months. And the numbers now are up in the thousands in terms of tests. But I think the salient points that you'll see is that in this lower graph here, this is the number of positive tests and in our pediatric patients, and it largely reflects the overall trends in the state of New York and New York City as shown on the right here. And so at this point, with the updated numbers, these are the numbers that we currently have. And as you can see, there continues to be a rate of positivity in terms of asymptomatic patients and caregivers, and the rate of positivity in terms of SARS-CoV2 is obviously higher in symptomatic patients, but this still does underscore the need to continue with surveillance, even in asymptomatic patients who need to undergo procedures, for example. This is a distribution from our latest set of numbers. And as you can see, in terms of the patients, there is a skewing again towards solid tumors, reflective of our demographics. Most of the patients are on active chemotherapy. And interestingly, we had originally described a very significant skewing in terms of male to female ratio that I think at the beginning was something like a 14:2 skewing. That number has obviously increased with a greater number of tests being done. We still see a very significant skewing. In terms of the percentage, this is lower than the original report, but because of the larger numbers, the p-value is even higher. Now, this is a point of some debate because there are other data sets that suggest that there is no skewing in terms of positivity and infection, but our data continue to be highly significant in terms of a male skewing. I would also underscore that there is another sort of voluntary data aggregation source, the Pediatric Oncology COVID Case Report Consortium. And in this consortium, which better reflects the distribution of diagnoses with more heme than solid tumor, there is also this skewing in terms of sex distribution. And so I think this remains a point of question, but we would suggest that this would one would have to consider that there is biology underlying this skewing. It continues to be the case with the larger numbers that 95% of patients have very mild disease. We've now had 6 patients who required hospitalization for COVID symptoms. It is notable that they are all sort of heme, transplant, and severe aplastic anemia patients, and we'll come back a little bit to that. We've had a number of patients who've needed to be hospitalized, but for reasons other than COVID symptoms, such as fever, neutropenia, or progressive malignant disease. The mortality rate continues to be 0 through this. In terms of recovery, we initially had been following patients with PCR as a determinant of whether they needed to could come off precautions. We all now understand that this is not a good way to determine recovery. And we had a number of patients that had very long duration of PCR positivity that we now better understand is prolonged viral shedding. But this is no longer a relevant way that we discern recovery. Also, early on, we did do antibody testing and very quickly learned that the presence of antibodies was really not predictive and not indicative of recovery. And so that too, we've stopped doing. And so it raises the question, you know, is this skewing that we see towards heme patients indicative of some underlying biology? And this is where, if you look at the larger group within Memorial Sloan Kettering, the adult group had also found a similar association that heme malignancies, in addition to lung cancer, was a risk factor for infection and severe disease. And through a very large effort across the institution, we're now starting to understand why that is, but more importantly, to understand how is it that these patients who have heme malignancies on therapies that may be impacting their immune system, how are they recovering, especially if they're not recovering through generation of neutralizing antibodies. And to summarize a lot of work from other people based on single cell sequencing work and phenotyping in that way, we've started to discern multiple ways that patients seem to be reacting to COVID-19, including a cluster that is associated with the heme malignancies. And it is of interest that these heme malignancy patients do exhibit Bcell suppression, but there is not increased mortality within this group. which really raises the question, how do these patients then compensate for the lack of humoral immunity? And the evolving work, and I think this has now recently been published, suggests that that these patients, these heme patients who are not mounting an adequate humoral response, may be actually recovering in part through activation of CD8 T cells. And this is looking at, for example, the flow of immunophenotyping of a heme patient compared to a solid tumor patient. And so we are now interrogating some of these questions in our bank samples from our pediatric patients to ask the question, how do our patients who do so well with heme malignancies, how have they been able to recover? But also interrogating the question of those patients who never became positive in the setting of a positive caregiver. Do they in fact have TCR signatures and other immune signatures that would suggest that they actually were exposed and mounted an adequate response? Now, in terms of the impact on the practice of cancer medicine, I would point out that we also saw a very brief dip in terms of new visits, but this is largely recovered even within 1 to 2 months. And so that was just a very temporary dip as we learned to surmount the lockdown. Our clinical trials portfolio remained open throughout the height of the pandemic, and that too also recovered very quickly. And in terms of sort of the silver lining, as was alluded to already in the first talk, if you look at other types of infections, it's quite remarkable in terms of the other respiratory viruses through this pandemic. Literally across our entire practice, we saw 0 cases of influenza. And so, social distancing and masking really, I think, help pay dividends in terms of this aspect. And this is probably the silver lining from the pandemic. And so our conclusions from our experience are that morbidity and mortality from COVID-19 in the pediatric cancer patient is no greater than or not discernibly greater than kids in general. It's very low. That the current mitigation measures are really quite effective in terms of protecting caregivers, healthcare workers, and patients, and that recovery from SARS-CoV2 infection is not always associated with antibody titers, and that we are currently still assessing T cell activity as a way of patient recovery. The caveats that we've taken from this in terms of our practice is that even as we face the second wave, it was clear that we should not be delaying cancer-directed therapies if there are any significant risk that the delay may impose because of the almost uniform mild symptomatology, and that in our own practice, we continue with treatment, and we do so in an unsegregated manner, so we don't have a special COVID unit, COVID section, but that with the measures that are in place, we can protect healthcare workers and other patients adequately. So thank you for the opportunity to tell you our experience, and happy to entertain questions with the rest of the group.